Let's go. Welcome to Gatekeepers Journal Club with your host, Dr. Jeff Dikis. Tonight, I am joined by Calvin Rushing, coming to us from Dallas, Texas. How you doing tonight, Calvin?
Good, Jeff. Thanks for helping me log in, man.
Absolutely. We came in spinning on two wheels and made it right under the buzzer. So we're ready to rock, ready to roll. Tell everyone while I get the PowerPoint loaded up, tell everyone who you are, where you practice, and why we should care what you have to say.
I don't know about the last part, but yeah. So Calvin Rushing, I'm a board certified fellowship trained podiatric foot and ankle surgeon practicing in Dallas, Texas. I'm the director at the Dallas Advanced Foot and Ankle Reconstruction Fellowship. I got into podiatry because of a missed syndesmotic injury by a couple orthopods that caused me to limp around in college for about a year and a half, 2 years as a lower ankle sprain. That kind of started my obsession with syndesmosis and the first patent and some designs. And that led to my obsession with the ankle in general, because I came out and practiced from fellowship when COVID was going on. And that was not a fun time to come out and practice. A lot of us didn't know if we would have jobs coming out of fellowship with COVID. So my first year and a half of practice was basically ankle fractures and calf fractures. And so that kind of led into my interest in ankle fractures. But again, I'm a young guy. I'm very enthusiastic, very passionate, obsessive about things that I choose to be obsessive about. Jeff, I don't know if that answers the last question, but I don't have a lot of hobbies outside of foot and ankles. So that kind of makes me, I have a lot of free time outside of my kids. So kind of obsessed with foot and ankle in general.
Yeah, let's get right into it, and we'll start talking about all these things. The articles that we're going to be talking about tonight are two separate articles. First is comparison of ankle fracture fixation using intramedullary fibular nailing versus plate fixation, Journal of Foot and Ankle Surgery 2024. So basically comparing plates versus fibular nails. Because I think it's still a lot of people out there are hesitant to adopt fibular nails, and you understand why. They've probably fixed 1,001 different ankle fractures with a plate. Most of the time they do fine. They're thinking, hey, why do we need to adapt this new technology? We could talk about the pros and cons of each as we go along, and we'll get to that. The second is injectable vancomycin contained within a hyaluronic acid impregnated alginate carrier, novel technique for prophylaxis against surgical site infection. Do they not limit the length of the title? Do they not cap that? Like, Twitter, 140 characters? Like, golly, that's a lot of words. But basically looking at topical vancomycin powder. So we'll touch on both of those as we go. And not to be left out, this is my very own article looking at surgical site infections on vancomycin powder from back in 2015 with Dr. Wukic. So let's spend like 3 minutes talking about vancomycin powder and its use of why we would care about utilization of vancomycin powder. Give us your thoughts.
Yes. I mean, Jeff, you were on this article originally. This is a great article. I mean, I remember when I was a guy, you're older than I am. So I was probably a resident still, like maybe a student. We knew when you guys published this is a great article. We know diabetics have higher rates of infection and then complications in general. You guys in this article showed what? This was a 73% reduction in this patient population, overall. And, the vancomycin makes a lot of sense. And I think all of us have used vancomycin. I'm a big fan. I love this article. But the issue with vancomycin is a couple of different things. Number one, you put it in, it's so soluble. And you've seen this too, Jeff. I saw this. You put this in, you put the powder in, the slurry, you make it rain, whatever you want to call it.
Mm-hmm.
And then afterwards, in some of these patients, particularly the non-compliant patients, which that's the population that we like to put this in.
Yeah.
They drain, they macerate that surgical incision, and vancomycin is soluble. It hits a peak concentration within about 6 to 8 hours, and then it's kind of gone. And, my whole thinking with vancomycin was, we know that it works, but how do we reduce the solubility? How do we make it last longer? How do we stop that peak? And how do we get something that makes it sustained over, instead of 6 to 8 hours and then falling off after that gradually? How do we make this vancomycin last? So that's kind of my impetus for trying to find a carrier. And I do think that we're going to see a lot of drugs, whether it's local anesthetic, anti-inflammatories, vancomycin. I do think we're going to find a lot of carriers that give us the benefit of these drugs without basically the side effects and the complications. So that was kind of my impetus to kind of experiment with vancomycin. It's positively charged. The hyaluronic alginate graft that I chose to combine it with is negatively charged, so they bind together. It's all natural. It's from alginate sea kelp. And we can actually get, instead of getting that peak concentration within 6 to 8 hours, we can actually get this sustained over 3 to 4 weeks. And we can also reduce that solubility so we're not getting those incisions that macerate and drain. So it was kind of just something that I stumbled upon. At the time, I started doing this about 2.5 years ago, 2.5 years ago, and the technique's been modified since then. But I've been super happy with my infection rate. I'd always tell the fellows, don't do some of the stuff that I do unless you're going to copy everything that I do, because I hate infections. You hate infections. As foot and ankle surgeons, we have higher rates of delayed wound healing, dehiscence, surgical site infection than any other orthopedic subspecialty in the body. And I tell my shoulder colleagues all the time and my hip colleague all the time, if they get an infection, it's like one every 3 to 4 months. Like, how many infections do you get, Jeff? More than that. Post-op.
No, never. I never, because I put vancomycin powder
Yeah. Yeah. No, I mean, but again, like our orthopedic colleagues, our partners, they don't have that rate of infection. Whereas for us, if you look at some of the articles, it doesn't matter. Take total ankle, take ankle fusion. If you look at Kent Hunt's research, complication rates at 50%. Right, that's a pretty high complication rate. That's a pretty staggering number to put. So anytime I'm doing advanced reconstruction, I'm doing revision surgery, which is kind of my thing. I love revision surgery. I love kind of figuring out what someone else couldn't figure out or what fell apart. That was really my impetus for trying to take your article or Dr. Hukish's article and basically try and take all the positive benefits of vancomycin and also reduce the solubility, reduce the postoperative maceration and drainage, and also stop that really quick peak that we see that then it quickly falls off. So that was kind of my rationale for combining it. It ended up working out better than I thought it was going to work out. There's products coming down the market that combine vancomycin with carriers. I don't get any. I get a pat on the back for those things that will come out, but that's about it. But at the end of the day, it's as foot and ankle surgeons, we have a really hard task.
It makes a lot of sense. Just, it's cheap, it's easy, it's on the shelf, it's ready to go. And if we can make it, our article was put out 11 years ago. So why shouldn't things improve, get better, find a different way of doing it? So you and I are both in agreement on the utilization of vancomycin powder. I'm going to run through these articles real quick just to give people an idea of some of the things that you've published. Syndesmotic instability, injury 2025. Syndesmotic reduction, the foot 2025, ankle fracture fixation, intramedullary fibular nailing, fast track 2023. The one that we're talking about now, minimal incision management, rear foot and ankle trauma, Sonics and PodMed Surge 2025. You get the idea. There's a lot of articles that you've put out there, and that's fantastic because that's how we get better. We learn from each other and we figure out, hey, we used to maybe do it this way. And in this case, we're going to talk about old ways of doing things and why new ways might be better, might be different, or maybe sometimes where we still utilize older techniques like plating. So talk about why you even considered fibular nails in the first place.
Yes, I was trained, West Side in Florida. We used a rigid 3rd generation nail. I didn't like some of the things I saw in the nail. So these nails, they're great. The issue with the rigid nails, there's a bend distally. I think your preference is for a 3rd generation rigid nail, Jeff. And I think it's a great nail. Some of the things I saw that I didn't like, with that generation nail was, it's rigid, number one. So if you come in too lateral, you can kick out that fibula. And I sent you a picture of that. One of my attendings when I was a first year resident put in this nail too lateral. And you can see that basically you put in too lateral, that bend kicks that fibula out, and the ATFL, the PTFL, the CFL, they're going to pull that talus laterally. And once that happens, you're basically burned. You can try and re-ream, but the nail's going to follow that additional path. Your only option at that point is to basically remove the nail, plate it. And so that's kind of why I started getting away from nails. I'll be honest with you, when I got out, I was plating everything. I got out, I thought, I don't want to mess with nails. I've seen so many complications from nails. I don't like that the trajectory of the syndesmosis locks you in at 25 or 30 degrees from the coronal plane. You're Your access might be 18, mine might be 26, someone else's might be 30. We know it varies. The research that showed that it was 25 or 30 was very limited in methodology. It was the best those orthopods had at the time, but we have better research now. So really, I was at the point where I said, okay, fibular nails are not there. They're not there. I'm not confident in fibular nails. I'm going to plate everything. You start plating things, and you know this, and I know this. You plate things, you get delayed wound healing, you get dehiscence, you get surgical site infections. That's a normal thing. Non-compliance is a really big issue, especially with patients down south where I'm at. Our BMIs are heavy. I think my average BMI for ankle fracture is probably 40 or 45. Everything's bigger in Texas. And so, I remember my first case ever, ankle fracture, plated it, big guy. In 5 or 6 days post-op, I was at the gas station. I saw the guy walking around, supposed to be non-weight bearing for the first, couple weeks. Walking around, hey, what's up, Dr. Rushing? He's getting sodas and getting a bunch of chips. I'm like, dude, what are you doing? He's like, what do you mean? I'm like, what? Like, what do you mean? What do I mean? I told you stay off this. He's like, I'll be fine. I'll be fine. He was a smoker. He dehisced. Patients. It's something that we all see. So then I started to kind of revisit fibular nails. And I said, okay, I don't like third generation rigid nails. I don't like that they lock you in for the syndesmotic trajectory. I don't like that they use cortical screws that don't interlock with the nail itself because that can back out. I sent you a picture of one of my sports colleagues who's no longer with us. He did a professional. No, that wasn't the professional athlete. This was a patient he did, and the nail it just backs out because it's poor bone density. When you talk about fibular nails, a lot of us, you included, probably started thinking like, I'm going to use this in the elderly, patient who's minimally ambulatory. Well, their bone density is terrible. So the other day, if you're using cortical screws that are depending on bone density, I sent you the X-ray. You can watch those screws back out, and then at that point, there were so many reasons to not do nails that for the first year I was out, I didn't use nails. I was determined to use plates and not use nails, and then eventually I started kind of looking at this 4th generation nail here. So if you look there on the left, you will see one of my attendings, great guy, awesome mentor. Allowed us to have a lot of autonomy. I was the first year. Our chief resident did this case. You can see that insertion for the nail. It's okay. It looks better than it is because it's more of a mortise image than an AP, but it's pretty lateral, and that bend kicks that nail out. Obviously, the ATFL and the PTFL pull that laterally, and they try to clamp this down. They try to put syndesmotic fixation across to suck that fracture back in. But with that bend in that nail, even though there's techniques to use the bend and these rigid nails to help with the reduction of fracture, placed in the wrong way, it can be the exact opposite and just create a nightmare. Whereas if you look at the 4th generation nails, and I started looking at this, they're straight, they're flexible, they're semi-flexible. If you look at the fibula, when we opening ream these things, we're reaming to a depth of 60 millimeters. That basically takes the bend out. So, you kind of ask yourself, why am I using a bend nail if I'm reaming 60 to 70 millimeters up with a 6.3 or a 6.2 millimeter reamer? Because at that point, there's no bend. That's where the bend is at, is about 55 to 65 millimeters. So you kind of start to question, why am I using a bent rigid nail if I'm proximal reaming to open up, and then the canal has been open with a straight reamer? I started using that 4th generation nail that you see there that's straight, completely flexible. I pivoted now to a semi-flexible 4th generation that you see there. But I switched from that 3rd generation to 4th generation due to the reduced risk of malreduction. The 4th generation nails have screws that interlock with the nail itself, so you get a true load sharing construct. Some of our European orthopedic colleagues, Fibular and others, have talked about sinking these cortical screws for the picture on the left down past the bone so that you get a true locking construct. I've done that. That's my case right there that you're looking at. And I did that revision for my colleagues, and I was happy with the reduction. I didn't like how lateral I came in. But nonetheless, I was down the centroidal axis for the syndesmosis, and those things, she had such soft bone. Those screws backed out. I think that's either 2 or 4 weeks post-op. Those backed out. So when I started seeing some of the complications from the 3rd generation nails, I kind of started to lean towards the 4th generation, basically creating a true locking construct. Super happy. The other reason is syndesmosis. We don't talk about syndesmosis a lot. I tore my syndesmosis. I'd misdiagnosed for a year and a half. That's the whole reason I changed from psychology to foot and ankle. Um, we don't talk about syndesmosis enough and the reduction of syndesmosis and what that looks like, but you can malreduce a syndesmosis so easily and you have no idea. The cotton hook test is 50% accurate at that. External rotation is 50% accurate, maybe 40%, depending on what literature you're looking at. But I see people all the time that will take a hook, and I had some of the attendees of the fellowship with me. They'll take a hook and they'll pull this fibula. If you look at the research, it says 100 newtons. I challenge anyone to buy a force gauge on eBay, put it on the fibula on a cadaver, and pull. I see how much 100 newtons. It's a lot. It's a lot. I'd never seen an attending pull with 100 newtons, and so when I got a force gauge, I attached it, I pulled it. I said, "Oh my god, this is an insane amount of force." Like I've never seen any attending in the world actually do a cotton hook the way it's been described with 100 newtons. So again, this was from an ortho a revision I ultimately did, but you can see even with unicortical syndesmotic fixation, you can be off axis. And this patient came to me, a year and a half afterwards. She was told everything's fine by him, his colleague, his PA. And I took one look at the x-ray and I looked at that lateral and I told her, I'm like, look, syndesmotic fixation's high. It should be the anterior half of the tibia. You're not crazy. We'll get a CT scan. We got the CT scan. Obviously, that's malreduced. It was such a simple revision. I removed the hardware, scoped it, directly repaired the ITFL. She did amazing. So again, like ankle fractures are something that we haven't got. It hasn't gotten the attention it's deserved. Syndesmosis kind of gets relegated to the end. We focus on length, rotation, angulation of the fibula. We talk about the posterior mal and the medial mal. When we talk about syndesmosis, it's kind of an afterthought. And it's really, really important when you start talking about the nails. I've seen a number of nails around the country break, the flexible nails at least, where the length, rotation, angulation of the fibula is good. But you look at the axis of the syndesmosis, and it's in the posterior half of the tibia. And I've literally seen some of the flexible nails just snap in half. My colleagues have said to me, like, dude, look at this. And I'm like, it's not the nail. You were off axis. You malreduced the syndesmosis. It created aberrant stresses, and that led to the fracture and surgeon error. So for me, really the fourth generation, the nice thing about those straight nails, they're flexible or semi-flexible. You get them in easily. They have screws that interlock with the nail itself. It's a true load sharing construct. And you and Bird just talked about this, I think, a month or two ago, how, AO, absolute stability, you don't really need it. Even if you're doing a plate and screw construct, you don't need a lag screw. I mean, we're relative stability, early micromotion, early range of motion, that's advantageous for patients.
Yeah.
So at the end of the day, like when I started looking at this, the fourth generation nails are just so superior to the third generation nails.
Well, don't sell us too hard, because someday there'll be a fifth generation and you're going to tell me how bad the fourth generation is. So tread a little lightly. I'm sure they're better than the other ones, but they're the best we have for right now. On that syndesmotic fixation, I think it's interesting. You look at the AP and the component that's in the tibia looks okay. And then you look at the CT scan and you see that the hardware is in the incisor. It's in between the tibia and fibula. It's interesting how much more you appreciate on CT scan. And I think we accept a lot of, hey, it looks okay on x-ray, but you and I could look at that lateral and know that syndesmotic fixation is not going to be ideal. And so getting CT scans there, verifying that, like you said, you did a simple thing relatively, and fixed her, made her better. So syndesmotic malreduction is a problem. And like you mentioned, one of the issues with the fibular nails is malreduction. The last thing you want to do is have a piece of technology, surgical technology, that is causing malreduction. We're trying to improve reduction, stabilize. It doesn't always happen. I've used those fibular nails like you've talked about and done just fine with those, but I have had some where if you don't put it in exactly right, it kicks the distal fibula fracture out, and I had to bail. I had to pull it. Like you said, I don't remember if you said it was an attending or something. It was like clamping it. Like, nope, you don't even bother that. You're not going to overcome the power of that nail. Pull it out, plate it, move on, chalk it up to a bad day, whatever, and move on. So that definitely happens. So talk about your technique. I think this is interesting. How you figure out the optimal alignment of syndesmotic reduction.
Yeah. So for me, there's a lot of orthopedic colleagues that did a lot of good work, and we don't give them enough credit. And when you look at syndesmotic reduction, and if you go back to that last slide, that's a great slide to show that, we were taught, you probably too, I was taught the syndesmosis is 25 to 30 degrees from the coronal plane. That's the transmalleolar axis. And so what that picture on the left is showing you is that really it depends on what the position of the limb is. So if you have somebody who's in a normal position, which is number 3, yes, you are 20 to 30 degrees off that coronal plane. Well, what's the first thing we do in an ankle fracture? We put a bump under the hip. So if we put a bump under the hip right away, we're not at 30 degrees. We're less than that. So if you're keeping that 30-degree angle and you put a bump underneath the person's hip and you internally rotate them and you keep that angle, look at what happens at number 1. You're too anterior. Conversely, if you have somebody who's a dancer or someone who's their BMI is a little bit heavier, you don't bump them and you keep that same angle, you can come out posterior, which you see right there kind of in number 4. So really, this was Kennedy did a study, and this was basically a radiological study where he said, okay, the goal of syndesmotic fixation is just bring the tibia and fibula together. That's it. That's all we're trying to do. We don't want to introduce a secondary anterior posterior force. All we want to do is just bring these two bones together. Again, most of the syndesmotic fixation is not side to side. It's usually anterior posterior. After that is external internal rotation. And then lastly, it's coronal plane.
So tell us about this center technique though.
Yeah, no. So the center technique is Yarborough described this. He's a traumatologist, and he basically said, "How do we make sure we're getting on the right axis?" So if Jeff's axis is 20 degrees and mine's 30, that's very subjective. How do we get to the perfect axis for everybody? And what he described was basically an internal rotation maneuver. You basically take the limb, you internally rotate it so the fibula is dead center with the tibia. You can keep your hand parallel to the coronal plane, and you fire straight across. When you do that, and you insert fixation, your fixation as it goes in is not going to introduce a secondary force, anterior, posterior, external, internal. It's simply going to bring those two bones together, which is kind of the goal when we're doing flexible fixation. So I kind of took the work by Kennedy and I took the technique by Yarborough and applied that to fibular nails. You've done a ton of nails. I've done a ton of nails. We don't really think about rotation of the nail usually. Usually we think about length, rotation, angulation of the fibula, right? But the rotation of the nail matters too, especially with these newer 4th generation nails, because if you look at the 3rd generation nails, and there's a number of companies that have those, they're all angled at 20, 25, 30 degrees off the coronal plane. But the newer 4th generation are 5 degrees. That's all the angulation is inside the nail. So truly, as the surgeon, you have the control of where that syndesmotic fixation is going to exit. So what I teach all the fellows is right away when we insert the nail, we pay attention to the rotation of the nail. We internally rotate the limb. We manually reduce the syndesmosis. We check the articular surface. And there's no guesswork. We're not depending on a jig. We're not depending on subjectively what we think it may or may not be. We know definitively, it doesn't matter if it's a 22-degree angle or 25 or 30. No matter what it is, it's going to be perfect. We're always going to be down the center because you align the center of the fibula with the center of the tibia. And this is something that Yarborough described back in, I think, 2011 or 2013. Kennedy also showed that radiologically. Chris Rebb, 2 or 3 years ago, did a CT study on this out of Gainesville, Florida, and showed that if you do this technique and you obtain post-operative CT, it's dead on accurate. So this has been shown to be a very accurate technique to make sure that the syndesmotic alignment is perfect. You can see intraop. This is exactly what it looks like. It's extremely easy to perform. So here, everything's been reduced. The nail is in, and all I'm doing here is internally rotating the limb. And once you internally rotate the limb and you align that fibula in the center of the tibia, you can provisionally fixate it, and you can just keep your hand parallel to the table. There's no subjectivity. There's no guesswork. You're not throwing a wire going, oh, I'm too anterior. Oh, I'm too posterior. Let me pull that back out. Let me adjust the jig. Some of these jigs are big and bulky. And so if you're not paying attention, and I think about, there's an upper extremity company where the jig is massive. It's used for the distal radius as well. And if you're not careful, you'll put a bump underneath the ankle. The jig itself is going to touch the table. It's going to offset where you're at rotationally. And that used to drive me crazy. So the 2 nails that are the newest on the market have very small jigs. They're not going to offset where you're at. And so that's kind of where I got that technique from. So you can see once you enter in here, you insert the nail. No one thinks about the rotation of the nail. So as soon as the nail gets in, we go to a center technique. Once we're in the center technique, you can see, and you don't want to look too high. So in this technique, you want to basically look 2 centimeters up. So there's the physeal scar there. You can see I'm kind of looking at where that first syndesmotic slot is. I want that to be in the center of the tibia or slightly anterior. Once I'm there, every time you insert a nail, it's not going to be perfect. It's going to be a little turned anterior. It's going to be a little turned posterior. So I'll tell the fellows, basically grab the nail, attach the jig, or grab the nail before you attach the jig and internally rotate it so it's a perfect circle. So you want those perfect circles inside the center of the fibula. Fibula's dead center of the tibia. And if you do that and you attach the jig, you reduce it and you drive your syndesmotic fixation across that center, you check your reduction, you don't have to do anything else. You already have K wires across the syndesmosis. Your reduction is done, and essentially it's drill and fill. It's a very easy process from there.
How often do you think malreduction of the syndesmosis occurs? Because I see it all the time. And I think some people just, if they're doing a nail, they just put in the nail and then wherever the syndesmotic alignment is, that's where they put it, and they put it in their craftsman screws and they're done. And even when they do plates, they just put in their syndesmotic fixation and they're done. They look at an AP, boom. And they don't appreciate on a lateral. They must not take a lateral because they wouldn't leave it like that. Or I hope if they were my surgeon, they wouldn't leave it like that. But, and to be fair, I've done 1,001 syndesmotic repairs and I'm not perfect every single time. There are times where I'm deviating off like, that is not quite what, that's why I throw a wire every single time. And then I drill, because if I don't like it, I'm going to fix it. Going back to the example of the girl who had the malaligned syndesmosis, if you don't get that right, you can take a rather simple fibula fracture and turn it into a new problem. If you fix the fibula, but you malreduce the syndesmosis, all you did was swap out a bone problem for a ligament problem. How often do you think that's happening realistically?
Realistically, probably about 50% of the time. If you're using flexible fixation and you look at Sebastian, I guess, Bombach's article, a lot of times, if you're using flexible fixation, whether it's 1 or 2 or 10 to 15 degrees divergent between those two, you get spontaneous correction in a large amount of those patients. But at the same time, I always tell the fellows, don't depend on flexible fixation. Don't depend on just do things right. Intraoperatively do it right the first time. Don't try and get lucky. Just do things that we know work. I think syndesmotic malreduction is pretty common. I've done a lot of cases where you just cut the rope, scope the ankle, re-reduce it, or reconstruct the ITFL, and patients think you're just like the best thing in the world because they had pain for 2 or 3 years. They were told they're crazy. They saw the ortho. They saw the other ortho's partner, the general joints guy. They saw the PA. They've been on pain med. They've been told nothing is wrong. And I see them. I'm like, no, something's definitely wrong. And you do a very quick surgery that changes their life, and they think you're the best, the next best thing. And it's just such a simple mistake that people make.
So if you're primarily fixing only the AITFL, are you saying you take out the syndesmotic fixation and then you primarily repair the AITFL?
So that's evolved for me. So I'll tell you that I used to do 2 dynamic fixation devices predominantly, 15 degrees divergent.
Mm-hmm.
I migrated away from that because there's some good research by Berger and others that shows that if you are putting syndesmotic fixation above 2.5 centimeters, and we know that first, and on all these nails, these locking screws with these screws that go across, they're all about 9 to 10, 15, 16 millimeters up from the distal fibular tip. Most of those syndesmotic slots start at about 1.8 to 2 centimeters up from the plafond itself. So, if you do that, you're safe. But if you go above that, Berger and others have shown at Foot and Ankle International that there's a very high risk of injuring the anterior perforating artery off the peroneal. And so I went away from doing 2 flexible fixation devices to doing 1, and then either directly reconstructing the ITFL, or whether it's with anchors, Vicryl in some of these young, healthy patients where you've got a nice thick ligament. Or if I have a case like we saw last week with Dr. Rivera before she graduated, sometimes you do a scope and you can literally see the avulsion of the ITFL and there's just cancellous bone in the scope. And so right away you're going to use some kind of synthetic graft. I've done that just because most of the syndesmotic fixation is not coronal plane. I mean, I always tell the fellows, I'm like, think about the tibia and fibula. Most of the motion is front to back, external, internal. If you're call it a piece of floss. If you're putting a piece of floss between the tibia and the fibula, and you're trying to pull these things together, how much resistance front to back do you think you're really getting? You're getting resistance to diastasis, no doubt, but that's the least amount of motion in syndesmosis. So how much anterior, posterior translation, internal, external? Not much. Whereas if you go in and you just repair the EITFL, you will lock up that sagittal plane translation. You'll lock up external internal rotation. It is absolutely the most solid construct to do a single fixation device, flexible, and then turn around and do the EITFL. Like, I've been so happy in the last year and a half since I switched to that.
I would caution people, and I'm sure you agree with me, that if you need to be careful not fixing the syndesmosis and only doing a direct AITFL repair, because if there's posterior instability, you're going to malrotate and gap posteriorly, which is still malreducing the syndesmosis. Although not as common, I think, but just be careful with that. So you fix the syndesmosis first, or you ensure that you're not tightening down the AITFL too much, because then if you think about that, that would posteriorly gap.
Yeah. So, 100% agree with you, Jeff. So I would, when we do this, we do posterior mal first, medial mal second, after we do scope. We do obviously stress everything under arthroscopy. We put the nail in, we do a manual reduction of syndesmosis, and then I don't know about you. We know the cotton hook is useless. It's 50% accurate. We know external rotation is even crappier as far as accuracy, and it's very subjective. So if you, me, and 10 other surgeons got together and said, "Hey, like, let's disrupt the syndesmosis," I've done this. I've done this in the lab. I've probably done 50 or 60 cadavers where I section a syndesmosis, the superficial deltoid. I created that scenario. I brought attendings from residency fellowship just to the community. I said, okay, stress the syndesmosis, cotton hook, what's unstable, yes or no? And it's terrible. There's no agreement whatsoever. I used to palpate the more proximal aspect closer to where the syndesmosis is at. But even that is subjective. I might touch that and I would say that feels reduced and that's great. You might touch that and be like, "Cal, that's not produced." Whereas if you look at that anterior lateral articular surface of the talus, I could take my brother, I could take my brother and my mother and teach them what to look for. You can't mess up articular surface reduction. And so that's really where I kind of migrated to.
Are you scoping sorry, I didn't mean to cut you off, but are you scoping every ankle?
Not every ankle. Sometimes things come in overnight. There's a bunch of knee scopes the next morning.
Why would you scope? Let's say that scope's available, it's ready to go. Why? Yeah. Which fractures are you? Yes, we should scope that. And which are you like, nah, I don't need to scope that?
I used to probably be 70-30. And I would say, look, if somebody's really old and this is not the right way to think about it, obviously, but, I used to think that if someone's old, they're 80, 75, 80, yeah, I could lavage the joint. I could evacuate the pro-inflammatory cytokines, there's tons of guys that have done that research and showed benefits to the cartilage, but they're 75, they're 80, at the end of the day, like, let's just fix the fractures, get them back walking. I've kind of come back and gotten more aggressive with the scope. It drives the fellows crazy because I'm like, the scope is 6 minutes. The scope is 6 minutes. If we don't see anything, get in, get out, lavage the joint. I've gone to about 100% scoping now. I don't chase things. I'm not, I'll pick up obvious osteochondral lesions. Like, if there's an obvious defect, some guys like Dracos have put out articles, man, and they'll say, like, oh, well, there's a 90% incidence of osteochondral lesions. I don't see that. I don't 90%. There's no chance. I'm not talking about the lesions where the cartilage is soft, you're taking a probe and you're really, really looking because you have an MRI. I'm talking about the obvious osteochondral lesions, all addressed.
If you push hard enough, you can create your own osteochondral defect. Then you can repair that. Then you bill it, and you just move on. So, also, if you jam something in there hard enough, you'll get a couple OCDs in there.
That's it.
Here's one.
Every fellow does this every year. Like, what did you just do?
Yeah. Uh-oh. All right. So what are you? I mean, mainly you're looking for osteochondral defects, and we've talked to Ryan Rigby before about the drive-through sign. That's less than an unstable fracture, but maybe you fix the fibula, then you scope. Do you do any of that kind of stuff?
Yeah, so I take a probe, but we take the shaver. We use a large shaver. I always tell the fellows, you can see the AITFL. So if it's avulsed, you can see the AITFL. I think that the guys that are not scoping, I've always thought, I was talking to my shoulder partners the other day, because he was asking me why I scope so much, why I have so many ankle scopes every year. Just out of curiosity, because we like to learn from each other. And I was telling him, I'm like, look, at the end of the day, I do think that if you look at the incidence of people who are plated, no scope, just plated, a lot of those people have anterior lateral impingement 2 or 3 years down the line. I do think, and I've when I'm scoping, some people have that true AITFL. Some people have that second or third vesicle, right? So I do think that if you're scoping and you're not at least debriding that lower vesicle that's hanging down, I do think that contributes to anterior lateral impingement. I haven't read a study that said that. It's level 20 evidence. It's just something I've observed. I always tell the fellow, at the very least, just if you see a vesicle, even if you can't get that probe up between the tibia and fibula, that 4 millimeter probe, just for the sake of saying that we did it, take that lower vesicle and just debride it, so we're not dealing with anterior lateral impingement in 8 months or 12 months.
Yeah.
I think Ryan's pretty aggressive with his deltoid repairs. I will stress the anterior lateral ankle, because you've seen this too. You've seen ankle fractures where you would think there's no involvement of the ATFL, and there is. And the ATFL is completely unstable. I'm not quite as aggressive medially. I think the superficial deltoid's involved a lot. In older patients, I'm not going to repair the superficial deltoid. Younger patients, I will with 2 anchors. But if I see that posterior tibial tendon, or you do, or anyone else does, if I'm scoping and I look over immediately, and I always tell the fellas, if you see that posterior tibial tendon sheath, that means the deep deltoid's avulsed. So at that point, at the very least, if we're trying to be minimally invasive, we got to repair the superficial. We don't have to go to the deltoid spring ligament complex repair like Deland described, which I like for flat foot. But
Yeah.
at least if you see that posterior tibial tendon, there's a problem. And the fellows hate the scopes. They hate the scopes because when they put in, I'm always like, okay, we're at 4 minutes, 5 minutes, 6 minutes, 7 minutes. I'm taking over in 2 minutes. But again, if you scope the ankle, you're going to find something. And I think you'd agree with that. Like anytime you scope an ankle, you're going to find something. Sometimes it's some things you don't want to find, like this. This was a young 21-year-old with just cartilage destroyed. I try to do a very judicious microfracture if I'm going to do it. I think some of my attendees were pretty aggressive in residency. You probably saw this too, where they're just pounding away. They're just pounding away, and you're like, I'm pretty sure we're doing more damage to the subchondral bone than we are as far as seeing cartilage. But again, I think you have to scope most ankles in patients who are younger and more active. And I would say young is probably 55 or 60. I don't think that we can call someone who's 55 or 60 that's active. I saw a 67-year-old that I thought was 45 today. That they were talking about surgery. I'm like, by the way, how old are you? And he's like, I'm 67. I'm like, there's no way. I'm like, you look like you're 50.
I get the opposite. I get people my age that look like they've been, a little rough. Drugs, man. Stay off the drugs. Don't smoke crack.
Oh, for sure.
Like Lawrence Taylor says. They get a little rough.
Gentlemen, which brings me to my next point. Don't smoke crack.
But yeah, I mean, you're not going to find what you don't look for. So if you don't stick a scope in there, then you're not going to find it. Ricky says, how often are you using a distractor when scoping? I would say I'm 0%. What are you?
0.
Yeah.
And the reason for that, I don't know. What's your reason for that, Jeff? What's your rationale for not doing distraction? What do you say?
I don't think I need it. I've never done a scope and thought, I can't get where I need to go. I can't, very if I maybe had a very posterior OCD, then I would consider about doing a distractor. Number one, it takes more time. Number two, you're putting traction on it and there's risk for nerve damage and vascular damage. Number three, I just don't find I need it. If I needed it, maybe I would gently apply a distractor and risk some neurovascular compromise, but I just find I don't need it.
Yeah. No, I'd say I agree with that. The reason I tell the fellows not to do it is, again, we stress everything. So I want the syndesmosis stressed. I want the anterolateral ankle stressed.
Yeah.
I want the medial structure stressed. The patient's under anesthesia. if you use non-invasive distraction, you're putting that longitudinal traction force on the calcaneus, you're tensioning the CFL. And if you're tensioning the CFL in a non-displaced oblique fracture, naturally you're going to tension soft tissue, capsule, and everything else. And you can literally sit there and try and stick a probe up into syndesmosis, and you think, you're like, oh, syndesmosis is stable. No, it's not. You're simply distracting down on the heel. It's tensioning the CFL. It's closing down the fibula. You have a completely unstable syndesmosis, but because of the distraction, you think it's negative. So I always tell the fellows, never distraction, never, ever, ever distraction. We can do any work we need to do with gravity alone.
How often, so let's walk through this. How often are you doing a mini open versus a percutaneous reduction before you're nailing? What are you favoring? And walk us through your technique.
Yeah, so I think that you and I could probably agree on this. So maybe not. Maybe Burgess and I would agree on this. So when I started doing this, I was doing everything percutaneous with a Hentelman on the fibula, and that worked great. The clams,
something like this.
Yeah, not that Hentelman. So if you're going to use a Hentelman, use the short arm, the thick, the stout arms that you would use for calc fracture. That is just something I had to use at the time because that's what the rep brought. Do not use that distractor. I started doing the indirect a lot for the lateral malleolus, which I think is different than the medial malleolus. So I think the medial malleolus, you absolutely have to make at least a 1 centimeter incision or a half centimeter because that periosteum, it's going to invaginate inside the fracture. I always tell the fellows, do not ever just throw screws and think you reduce the medial malleolus because you didn't.
It's so tempting too. It's so tempting, especially when you fix a fibula. You look at the ankle joint mortise, you're like, it's perfect.
Yeah.
I only have to throw these perc wires, perc screws. You might get away with it sometimes, but you are going to get burned and burned hard when that goes to medial mal non-union.
Yeah. And I've had 2 or 3, I always tell the fellows, I'm like, look, I'm the kind of guy where I have to touch the fire, right? And that's not a good quality. I have to see it. I have to feel it. I have to doubt it. I have to see it fail. And then I learn from it. I always tell the fellows, I'm like, don't be like me. Like, just listen to my failures, look at the x-rays. You don't have to touch the coals to realize you're going to get burned. But I've had some medial malfracture non-unions, and like that's like the worst thing. Medial mal non-unions, infected medial mal non-unions, they're nightmares. It's not.
If it's unstable, that's going to fail into valgus, and then if they're diabetic, we just got this huge train wreck on our hands that could have been avoided with a small 1 centimeter incision. Pull out the periosteum, get adequate or optimal reduction, not adequate, and then throw your fixation. So it turns into a train wreck in a hurry, or it can. Doesn't always.
100%. Well, for me, it does, but
everything's bigger in Texas. Listen, I live in Iowa. Texas State Fair is a big deal. We got the Iowa State Fair. That's just good people watching. So I don't think we got to that. How often are you doing mini open versus percutaneous?
Not often. I know I think you're a fan. You're a fan of mini open, right?
I am. I like to look at it. Like you said, you like to feel the fire and let it fail. I like to look at the touch bone with no interposing tissue. Like you said, the medial mal is constantly having interposing periosteum. Lateral malleoli, not as often, but I have seen it when I open it up. There's a little flap of tissue in there. I like to get that out of there, squirt a little saline in there, get my reduction, just directly visualize it, spin that down, clamp it, and I'm done.
Yeah, for me, I open the medial mal. I tried not to open the lateral mal just because, if I can get these, I always tell the fellows, if you get these within 10 days, you don't need a mini open. If you get like a simple fracture pattern that's not the butterfly, I hate the butterfly fragment. That, like, the bane of nailing is that butterfly fragment, because inevitably that wire is going to come out posterior.
I was going to say, so if I see a butterfly fragment or any combination, I'm not nailing. Are you still nailing, or what are you doing?
I'm nailing. I'm still nailing butterflies. I'm still nailing some combination as long as it's a Weber B. I sent you a picture. So tomorrow I've got bilateral ankle fractures, bilateral talus fractures, bilateral frank cuboid fracture, motorcycle accident, 22. That's not a nail, because that's a very low Weber A. It's convoluted. You saw that picture I sent you. The ATFL insertions involved, the AITFL's insertions. That's gonna be a nightmare of a case, right? But if I can get these Weber Bs, I'm always nailing unless it's more than 10 days old. This guy right here was like 23, 24, and
Yeah.
he came to me like 3 weeks after the fracture. There's no chance you're going to nail this. There's no chance you're going to do this percutaneously unless you do the mini open like you talked about. So in those cases where it's more than 10 days, sure, I'll open it up, butterfly fragment. I used to open up all the butterflies. There's a newer nail out now, some technology that lets us jump over those fractures, which is pretty cool. And so I don't have to just like open those. But even some of those longer spiral obliques that really come up, 2 or 3 centimeters proximal to that ankle joint line, even some of those I might mini open, just because there's a tendency for that wire to want to jump out posterior. Even if you oscillate it, even if you try and grab a mallet and tap it in, even if you try and do multiple reduction clamps, I've had 2 ankle fractures. You probably had the same where the canal is just too small. That's not small.
That's a bad day.
That's a bad day. That's a very bad day. And unfortunately for me, one guy was like he was just a massive man. He was like 16 years old. And I remember I'm 6'3", and he came in, he's like 6'5", like 310 pounds. I'm like, this guy is huge. I didn't even look at the canal because this was, 4 years ago. And I was like, this guy's a massive guy. He's a football player, scholarship next year. No problem. We're going to nail him, get him back quick. There was no canal about 110 millimeters up, and that turned into an absolute disaster.
Yeah.
And so I always tell the fellows now, I'm like, look, I know you're going to think about small canal with a female who's young, but you really have to watch some of these athletes. And we just had one. Every fellow's had one. Dr. Shohan had one. Dr. Rivera had one. Both athletes, both going on to play in college. Small canals, and it's not a good day when that happens.
Yeah, no, it's not. And I pay attention to that now. You only have to get burned a couple times before you're like, okay, I got to make sure I pay attention to the size of the canal. Look at that before I think about even nailing it. I broke off a wire trying to get up this fibular canal, let alone trying to get a nail up there. As soon as the wire broke off, I'm like, okay, that's a sign that this is not meant to be.
Yep. Yeah. So this is my original technique. You can see that there's those Hintermans. I love the Hinterman. I think it's great. I think with the traditional clamp that you can see, that traditional clamp, it's meant for a lot of different fracture reductions, not specifically the fibula. And so I think a lot of times with that, we do make a mini open incision, especially these patients that have a really big soft tissue envelope. And that's why I sent you a picture of some new instrumentation that there's a clamp that's specifically designed for the fibula. Probably a couple slides back, I think you showed the picture. But that clamp itself is designed, let me see. I could go back. That clamp right there. So if you go back one more slide, on the right there is the clamp that you and I traditionally use. And I think you and I would agree that sometimes we do have to make a mini open just to get that clamp around the fibula, especially that long spiral oblique, where we know that if you're using the 3rd generation nail that's rigid and you put that small clamp around and you take it off before you put that proximal syndesmotic fixation, you're going to get that sometimes you get that little kick out of that proximal aspect, that oblique fracture. If you look at the clamp there on the left, that's designed only for the fibula. That's designed for those butterfly fragments, those long spiral obliques. It's not meant to be used for any other fractures, but you can tell just by looking at it. It's longer. It's got a larger curvature there.
Yeah.
And so that was kind of the rationale for bringing that clamp to the market was just that the ability to reduce those longer spiral or those butterfly fracture fragments more effectively through a percutaneous approach. Not that there's anything wrong with the mini open, because there's not.
Well, it's hard sometimes. You can get the clamp on, but then you can't get it to the ratchet. So then you're just like sitting there holding it or trying to put another clamp on a clamp. Just because it gets somewhat close doesn't mean it's actually maintaining your reduction. All right, let's keep going here. This is flying by. Overcome the previous pitfalls that the first generation, you could say that about cars. Old cars had roll-up windows. Now we have automatic windows. That's a simple example of technology is going to constantly push forward in advance. We have to put something out. We have to try it, figure out, oh, that didn't work. Why? Well, this, and this. Let's figure out how to fix it and move on to the next phase of whatever we have available. So coming up to the end here, but what are your thoughts on, you know, this nail versus the original nails? You talked about some of these things, but talk about this real quick.
Yeah, so I'm a big fan of fourth generation. I think you like the rigid nails, don't you?
To be 100% honest with you, I'm locked into a hospital system that has contracts with certain companies that limit my ability to utilize certain products. We'll just put it that way. They dictate what I can and can't do for the most part.
Yeah, I'm a big fan of their so fourth generation nails, straight nails. They have screws that interlock. So I think, and probably you would know better than I would. I haven't used that nail in a couple of years. I think your favorite nail probably has cortical screws that don't interlock with the nail. But I think there's some new versions that just came out that they changed that. I think I just saw something like last week about a new launch of that nail.
Yeah, so there were some like little tips where you could just ignore the cortical screws, and I put in cancella screws, and it was kind of a tight fit. It was like a little squeak, but then I knew that it was it wasn't locking into the nail, but it was locking in because I made it lock into the nail. Because sometimes you put in those cortical screws and they're so small, and we're dealing with these little old ladies with terrible bone. You drill, you put the screw in, and what happens? I pull the screwdriver out, and the screw is still on the tip of the screwdriver. It was a stronger connection between the screwdriver and the screw than it was between the screw and the bone. And literally, I just pull the screwdriver out, and the screw is still on the tip of the screwdriver. So yeah, just like we talked about, anytime that you're going to have technology, you're going to have issues with it, and you're going to find a way to try to solve it. So this will constantly, there'll be a new one and a new one and a new one as we move along. So I try not to get too caught up on like this or that, because it's going to be constantly evolving. But like, if there's true issues, like don't use this because, or hey, we could find a way to make this work, or this nail has addressed some of those issues. Here's why this one might be better in some certain way. I think that's all very good for patients because, like I said at the very beginning, you showed a case of a malreduction of a fibula with a nail. All you did was put the nail in, you get malreduction. We've taken a step backwards. We haven't moved forward towards fixing it. We've created a worse problem than what we started with. So
Exactly.
as long as the technology is not hindering us in some way, that's ultimately going to be a problem. But modifying all these little issues that arise, because when you first start doing them, you don't know what the problems are. And then you do enough of them and you see, like we talked about with the small fibular canal, you just have to do enough of anything, and then you start to figure out what the problems are that you need to fix.
Yeah, I think you and I talked about this too. So my concern with the newer nails is, and I'm a big fan of one. I was number 2 in the country behind the guy at the core who was number 1. He and I, when the very first fully flexible quote unquote nail came out, he and I were every week. How many nails did he do? He did 3. How many did he do 2? It's like a friendly competition, a good spirited competition across the country between he and I. My concern with the fully flexible nails, I understand that the limitations of rigid. I think you and Burgess talked about that pretty concisely. I think you guys did a great job. My concern, I was telling you this with the flexible nails, is not in the typical Weber B. My concern is when we're making these work for comminuted butterfly fracture fragments, longer spiral oblique. I love a relative stability construct. My orthopedic colleagues, if you look at long bones, you trained at UPMC, relative stability, nailing long bones, that's kind of like the norm. There's a lot of advantages to that. You preserve the blood supply, you allow early range of motion, you facilitate micromotion, early weight bearing, reduce, convalescence period post-operative. My concern with the fully flexible nail, I kept saying this to every company and nobody would listen to me until one company did, was, I do think that a fully flexible nail in a bone that is supposed to bear 1/6 or 1/5 the load, depending on what study you're looking at. It's not just a buttress, it really is, but 1/6 the load is not nothing in someone who's 430 pounds or 350 pounds. My concern is that you might get a little bit too much micromotion. And I've seen that in a couple cases. I showed Shohan and Rivera every year. I said, look at these 3 patients. I've been watching them. Look at their x-rays at post-op year 1. They look perfect. Now look at post-op year 3 and 4. Look at the amount of arthritis they have. Look at the amount of bone formation. And so I think that, I think the rigid nails, you can use them to help with reduction, and the traumatologists have published articles on that. I think that's helpful. I've used rigid nails from 2 different companies, and in certain instances where I had multiple fractures to jump. So I had that, that Weber B, but then I had a really high Mason Newman. So I wanted a nail that was 310 to really get past everything in a patient. So I'm not always going to marry the 4th-generation nail. I've used the 3rd-generation nails too for the length. But I think that, I do wonder if we erred on the side of, okay, rigid has limitations. Now we're going to go fully flexible. And so that was why I kind of think that the middle ground or the sweet spot is a semi-rigid nail where we're still getting that solid fixation proximally and distally with a little bit of flex so that we can still, ease of insertion kind of thing. And I've, if you look at most of these nails, that proximal reamer, like we talked about, I don't know what the one that you use is. The ones that I use, it's like 6.3 6.3 and 6.2 millimeter opening reamers to a depth of 60 or 65. When you hit 65, there's not a curve anymore. So you just ream the entire canal. It's straight. So now you're putting in a curved nail for what? You just reamed everything open. It's a straight canal if you look at the cadaveric studies. So why are we using a curved nail if we're using these big opening reamers that ream out the curve of the fibula itself? So I think that I think there's much to come. I think there's going to be, like you said, multiple generations. And that's the point though, is keep putting out better nails, easier techniques, newer instrumentation until somebody comes out and just figures out kind of that holy grail.
Yeah. We do have a couple polls available if people want to vote on those. What is your current preferred fixation method for unstable distal fibula fractures? Right now, looks like it depends on the fracture pattern, is leading at 41%, plate fixation 32, intramedullary fibular nails 14. I used both equally 13. So there are more people utilizing fibular nails than I maybe would have guessed. I think that's a paradigm shift. It probably depends on the age. I hate to be ageist, but I bet if you found someone who's in their 60s and has been fixing fibular fractures with plates for their entire career, and they seem to do pretty well, just like some people still do a scarf because they swear by the scarf. And if they're good at a scarf, then go for the scarf. If it's good in your hands. But some people are willing to adapt with new technology, and some people are going to be more resistant to adapting to new technology. I think that's true. Probably some people have the latest and greatest iPhone. My wife keeps wanting to buy the oldest iPhone she can find because she says the new ones are too big. She's like, I need the smallest one. It doesn't fit in my hand. They're way too big. She's buying these old ass iPhones. Anyways, doesn't matter. We are up against the end here. There's another poll that says, how often do you currently use an intramedullary fibular nail? Routinely, occasionally, rarely. I've not adopted fibular nailing. I'm going to have to vote here so that it lets me see the percentages. So 50% of people have not adopted fibular nailing. So more than half of people have used, or at least sometimes use, fibular nailing. That's split among routinely, occasionally, and rarely. That's more than I thought. What do you think about that? Then we're going to wrap this up.
Yeah, no. So Dr. Rivera did a study, isn't published it yet, but she looked at across fellowships, ACFAS approved fellowships. How many of them really did a lot of nails in residency? Basically none. And I think that goes to your point that I think the easiest fracture, and I always tell the fellows, the easiest thing to do is open up a lateral mal. Dr. Bailey, when I was a resident, consistently did a lateral mal syndesmotic fixation in 13 minutes. Fastest I've ever seen it. I don't think I can do that in 13 minutes. But there's not really much difficulty to that. But if you look at the research, we know patients can mobilize faster. I don't weight bear right away like Burgess. I do toe touch and transfers immediately, full weight bearing by about 1 or 2 weeks, boot from weeks 2 to 4, brace and shoes at 6 weeks. I fixed ER doctors that are back at work at 6 weeks. And like, this is incredible. Like if I would have gone to so-and-so and gotten plated, I've been off this for 4 to 6 weeks. And then I've been in a boot for 4 to 6 weeks. I've been out for 3 months. ER docs, like they're busy. They don't have time to be out for 3 months. The recovery time is so much faster. If you look at the research, I think you and I can agree, any paradigm shift, even if you look at, arthroscopic rotator cuff repair, that was considered like, like who would do that when they first started doing that? so many things in orthopedics have gone to minimally invasive, but if you look at the orthopedic research, it takes 20 plus years. Like you really have to have just an overwhelming amount of evidence until people are like finally like, yeah, like maybe I shouldn't be doing this. And I always tell the fellows, first 6 months out, forget everything I taught you. I want you to plate everything. If you think that nails are terrible, plate everything. Let me know your complication rate. Call me. Let me know your complication rate. So I think that if you look at Dr. Vera's paper that she'll publish eventually, probably next month or two, she'll submit it. The learning curve is not as steep as you think. And I think you and Burgess talked about this. People are intimidated because they think it's a learning curve. I think that doing a lateral mal is easier than a bunion. It's easier than basically any procedure I can think of.
I'd much rather fix an ankle than a bunion. I hate bunions.
100%.
Day long.
100%.
All day long.
So I think there's always that. We know the research shows less complications, earlier weight bearing, faster union rates. It's cheaper in the long run, less reoperations. The literature has clearly shown nailing is superior to plating. It doesn't mean that it's easier. Plating will always be easier than nailing. But if you look at the survey Revere did, they'll come out. Most fellows said after 2 or 3 nails, they felt completely comfortable. So they weren't intimidated anymore. The learning curve is very quick. I would say start off with very easy fracture patterns first. But I think that, podiatry is no different than orthopedics. I think it's going to be a good 10 years before, the research finally becomes so overwhelming that people just have to go to nails because plating is just so easy. I'd rather plate a fibula than I would do a hammer test, right?
Oh, yeah.
That's just the reality of the profession. So we'll see, man.
Thank you so much for joining us. I think this has been a wealth of knowledge, and it is a constantly evolving topic, both from a technology standpoint and a technique standpoint. So I like talking to people like you, bouncing ideas off you, and hearing the things that don't work and the things that do work. I think that's how people end up learning. So hopefully we can shed some light on that for people. And thank you so much for your time tonight, Calvin.
Jeff, thanks, man. I started watching some of the podcasts. Big fan. You're doing a lot of good things, man, and super proud to have you on our side on the foot and ankle profession.
Thank you, man. Appreciate it. Rich, over to you. I do have to say real quick. Today is my birthday, and I chose to be here on my birthday because I love gatekeepers.
Honor and privilege, man. This is the best birthday you could ever imagine, man.
Nowhere I'd rather
Hosting
be.
gatekeepers? Come on, bro.
Nowhere
What more can you expect? There'll be some cake waiting for you, I'm sure.
Hope so.
Hey, thanks so much, Calvin. That was awesome. What a great discussion as always. Jeff, always a pleasure. We will talk soon, and have a great night.
Thanks, everybody.
Jeff, Rich, thanks, Jeff.
Later, man.
Bye-bye.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.